Welcome to this explainer. Okay, let's just dive right into the bloodstream to explore hematology, which is, honestly, the ultimate delivery and defense system of the human body. We're taking a high-yield, purely educational approach here to what I think is one of the absolute most fascinating subjects in medicine. If you've ever thought about how your body manages everything, from rapid oxygen transport to fierce immune battles, all while maintaining this incredibly delicate internal plumbing system, well, you're definitely in the right place.
So here's our high-yield roadmap for today. We're going to cover 1. Erythrocyte disorders and anemia. 2. Leukocyte disorders and leukemias. 3. Lymphomas and plasma cell dyscrasias. 4. Hemostasis and coagulation disorders. And finally, number 5, transfusion medicine and bone marrow transplantation. Let's hit it.
Starting off with Section 1, erythrocyte disorders, oxygen carriers and their failures.
First up, erythropoiesis. I want you to picture the incredibly high-speed production and metabolism of red blood cells going on deep inside your bone marrow, literally right now as we speak. It's this highly regulated 24/7 continuous manufacturing process. But, just like any complex assembly line, it totally relies on having the exact right raw materials at the exact right time. When those materials are missing, or say the cellular signaling gets crossed, the whole system starts to buckle. And that leads us straight into our first major clinical challenge, anemia.
Now, we're looking at two completely different factory errors here. Without enough iron, your body simply can't build normal-sized hemoglobin packages, right? So that results in tiny, microcytic red blood cells. On the flip side, if you have a lack of vitamin B12 or folate, that actually halts DNA synthesis. The cells desperately want to divide, but they just can't, so they end up growing larger and larger, eventually becoming those giant, macrocytic, megablastic cells.
So beyond just production issues, we also have to categorize red blood cell destruction. We look at inherited versus acquired hemolytic anemias, alongside structural hemoglobinopathies like thalassemias. Sometimes, the red blood cells are manufactured perfectly fine, but they're destroyed way too quickly out in the periphery. That's your acquired hemolytic anemia. But other times, the structural blueprint itself is just flawed right from birth, making those cells inherently fragile from the get-go.
Moving on to Section 2, leukocyte disorders and leukemias, when immune defenders turn rogue. Okay, grasping the four main leukemias, AML, ALL, CML, and CLL, really boils down to distinguishing two key factors. First, is the malignancy affecting the myeloid cell lineage, or is it hitting the lymphoid lineage? And second, is it an acute, rapid-onset explosion of immature blast cells, or are we looking at a chronic, slower-building proliferation of cells that are more mature but still totally dysfunctional? How we classify these fundamentally dictates everything about our clinical management and the patient's prognosis. But hey, it's not always an overproduction problem. We also have to be on high alert for a severe drop in our cellular defenders, specifically neutropenia and agranulocytosis. When your central white blood cell count plummets, your body's shield is essentially dropped to zero. This leaves the patient incredibly vulnerable to everyday run-of-the-mill pathogens that a healthy system would normally just brush off without a second thought.
All right, Section 3, lymphomas and plasma cell dyscrasias, the lymphatic system under siege.
Let's contrast Hodgkin lymphoma directly against the non-Hodgkin types. Hodgkin's tends to spread in a very orderly, highly predictable way, literally moving from one lymph node group to the very next. And that predictability is exactly why its staging protocols are so rigid and the treatments are pretty standardized. Non-Hodgkin lymphoma, however, that is a much wider, way more chaotic umbrella. It encompasses this massive diversity of B-cell and T-cell malignancies, which means you absolutely need a highly personalized diagnostic approach.
Moving even deeper into the bone marrow now, we uncover plasma cell dyscrasias. This includes multiple myeloma, the more benign-leaning MGS, and Waldenstrom macroglobulinemia. Basically, these disorders stem from a single clone of plasma cells that just goes completely rogue, pumping out massive amounts of a single type of antibody, known as a monoclonal protein. The big clinical challenge here? Distinguishing between MGS, which is usually asymptomatic and really just needs observation, and active multiple myeloma, which requires immediate, aggressive intervention.
Next up, Section 4, hemostasis and coagulation disorders, the body's mechanical plumbing.
First off, let's look at platelet disorders. We're contrasting dangerously low counts in thrombocytopenia with the abnormally high counts you see in thrombocytosis. But we really need to look closer at the specific syndromes. We have to distinguish immune-driven ITP, where the body mistakenly attacks its own platelets, from thrombotic TTP, where these microscopic clots literally consume platelets and just shred red blood cells in the process.
Both give you low free platelet counts, sure, but their underlying mechanisms, completely worlds apart.
Now, when the coagulation cascade collapses, we see some very distinct pathologies depending on exactly what's missing. In hemophilia, you're missing specific gears in the machine, right? Factor 8 for hemophilia A and factor 9 for hemophilia B. But von Willebrand disease, that's actually more about the glue. It's a deficiency in the specific protein that helps platelets stick to damaged blood vessels during the very first step of forming a clot.
And then we have disseminated intravascular coagulation, or DIC, which is just this chaotic, sequential breakdown of the body's clotting factors. Walk through these steps with me, because this is a true physiologic emergency. First, coagulation gets systemically activated. Then you get widespread microvascular thrombosis, so tiny clots literally everywhere. Because the body is so busy making all these tiny clots, it totally depletes its clotting factors and platelets in step 3. And ironically, that systemic clotting leads right into step 4, severe uncontrollable bleeding.
Finally, we arrive at Section 5, Transfusion Medicine and Bone Marrow Transplantation, Life-Saving Interventions. Now, before we even think about doing a transfusion, ensuring ABO and RH compatibility is absolutely paramount. I know it sounds basic, but safely matching A, B, AB, and O donors with recipients is the absolute bedrock of all modern transfusion medicine. Make one wrong move across these compatibilities, and the patient's immune system will literally treat that life-saving blood as a deadly invader.
But of course, even with perfect typing, medical interventions always carry risks. This is why we have to carefully consider blood component therapy indications right alongside acute and delayed transfusion reactions. We actually rarely just give whole blood anymore. We give packed red cells for anemia, platelets for bleeding, and plasma for coagulation disorders. Still, clinicians have to remain incredibly vigilant for adverse reactions. Those can happen immediately while the patient is on the table, or they can be subtly delayed, popping up days later.
When we look at hematopoietic stem cell transplantation, there's a massive, fundamentally important difference between using an allogeneic donor and an autologous self-donation. With autologous transplants, we harvest the patient's own healthy stem cells before hitting them with heavy chemo, and then we essentially rescue their marrow by giving their own cells back. Allogeneic, though, that is a whole different beast. We are literally giving the patient someone else's immune system entirely.
Okay, before we wrap up this explainer, let's really lock in this knowledge with a fast-paced, high-yield recap of everything we just covered.
We started with the cellular origins of anemias and rogue leukemias, moved through coagulation cascades, and finished up with safe transfusions and bone marrow transplants. We broke down the exact mechanisms behind erythrocyte and leukocyte disorders. We tracked the siege on the lymphatic system and the totally chaotic breakdown that is DIC. And we touched on the incredible power of stem cell transplants, right? Though, as we noted, it brings massive challenges, most notably graft versus host disease, or GVHD, where that brand new donated immune system actually decides to attack the recipient's body. These are your essential must-know takeaways. Which leaves us with this final, really provocative thought to chew on. As stem cell therapies advance and we get better and better at manipulating the immune system, how will personalized medicine ultimately conquer massive hurdles like graft versus host disease to totally rewrite the future of hematology? I mean, can we actually engineer a donor immune system that relentlessly kills the leukemia but perfectly spares the host? The answer to that question is being researched in labs right this very second, and honestly, it's going to change medicine forever. Thank you so much for joining me on this explainer. Keep learning, and I'll see you next time.